Yes, I've had a checkered career. I was also the Dean of School of Integrated Health at the University of Westminster. I'm retired now. I trained originally as an engineer and did my PhD in biomedical engineering before rediscovering CAM. I say rediscovering because my interest began a long time ago when I was a rugby-playing teenager who was very prone to knee injuries. Despite repeated trips to the physiotherapist, the only person who could get me back on the playing field was an osteopath. I didn't know how osteopathy worked. I didn't care. It just worked. I was back playing rugger again. Use of CAM. 2004, an estimated 5.7 million people in the UK saw a CAM practitioner. That's in a year, 1 in 10 of the population. Of these, 3.74 had used one of what's called the main 5 therapies: acupuncture, chiropractic, herbal medicine, homeopathy, and osteopathy. Though CAM is an umbrella word for much bigger, it encompasses a lot more therapies than the just 5 I've mentioned. But nonetheless, I want you to hang on to the fact that 3.74 million, about 1 in 15 people per year, back in 2004, consulted one of those 5 main therapies. Within the NHS, access to CAM, although not very widespread, nonetheless has increased markedly over the last 20 years. Acupuncture, for example, is used to help in childbirth. Hypnotherapy is used to reduce phobias or stress. Aromatherapy, interesting one, aromatherapy, is used to soothe patients who are in palliative care or help alleviate some of the side effects of cancer treatment. Indeed, the Cancer Research UK estimated that up to 1/3 of people with cancer use complementary therapies at some time during their illness. So, one wonders why then, with so many people using CAM, and in many cases paying for it out of their pockets, has there been such a fierce campaign waged against it? The commonest reason given is that there's insufficient evidence to show its effectiveness. When there is convincing evidence, this is often dismissed as being nothing more than the placebo effect. A patient expects a positive outcome, often there is one. Skeptics of CAM also take issue with how some CAM therapies are thought to work. Acupuncture, we've heard about, and homeopathy are good examples of that. The philosophies underpinning these 2 therapies are very, very different from how orthodox medicine understands both the cause of the disease and how people get better. Skeptics argue, therefore, that because many of the CAM philosophies don't fit within a conventional model of how the body works, therefore they can't work. And because they can't work, they shouldn't be offered to people, and the last thing you want is them being offered on the NHS. That's the argument. We've heard a little bit this afternoon about scientific fundamentalism. Interestingly, aspirin, the workings of aspirin for a long, long time weren't understood either. But that didn't stop aspirin from being used by both the patient and the doctor. Why? Because it worked. I'd just like to touch briefly on evidence-based medicine. When you see your GP, he or she prescribes a medicine, the doctor's choice of which is supposed to be based on published evidence. So today we have evidence-based medicine. But historically, medicine was informed by practice-based evidence. What was found to work with one patient was then tried with another. Again, aspirin is a good example of this, and it's only been within the last 40 or so years that a more systematic approach has been taken to collecting, researching, sharing good practice. The results of randomized controlled trials play a major part of what is now called the body of evidence for a particular treatment or drug. So, what is then the evidence base, the body of evidence for complementary medicine? This graph here shows the number of articles published over the last 20 years that have CAM as a keyword on the PubMed database. For those of you who don't know it, PubMed is the largest publicly available database of medical articles in the world. What's interesting is the steady growth in articles in this area. In 2013, up here, there were 65,000 articles published about CAM on PubMed in that year, 2013. The same year, by comparison, there were just over 1 million published on conventional medicine, so about 16 times more. So, although there's less published research than orthodox medicine, there is research that supports the use of CAM. Obviously, not all these articles are reports of randomized controlled trials, but there is now sufficient published evidence about CAM, and that's begun to change the attitudes and perceptions of key policymakers in the country. And a good example of this is in 2009, the National Institute for Health and Clinical Excellence, NICE, recommended to clinicians that a course of acupuncture should be considered for the treatment of persistent low back pain. So, does CAM have a role in today's healthcare system? Well, as I hope is obvious from some of the figures I've presented already, it already does. But the question is, should this role be extended? And if so, how? Let's just consider for a moment what's happening in the NHS today. Barely a day goes by when we're not told that the NHS is in crisis. Staff are increasingly unable to cope with the many demands of now an ageing population. The cost of the NHS has topped £100 billion. Sir Derek Wanless, in 2002, published a seminal report that for the NHS to continue providing high-quality healthcare for the next 20 years, the costs in real terms, i.e. not including inflation, would need to rise to between 154 and 184 billion pounds. That's 3 times as much as what it was in 2002, and about 1.5 to 2 times as much as today's figure, which is 100 million. Interestingly, this figure here was for a scenario where the public was much more fully engaged with their healthcare. So they took much more responsibility for their own health. So not surprisingly, the costs were lower. So, can CAM help? CAM could certainly help with some of the chronic illnesses associated with an aging population. This could lessen the economic burden on conventional medicine, so it could concentrate on an emergency and acute medicine, its 2 main strengths. However, for CAM to take on a greater role, will I believe, require 2 conditions to be met. One is we need more data and trials to show the effectiveness and safety of CAM for particular conditions as these compared to conventional medicine. The second is that more funding is needed. The average randomized controlled trial costs of the order of £7.5 million. Clearly, the pharmaceutical industry isn't that interested in funding what is perceived to be the competition, but perhaps the health insurance companies might. So how can we move this forward? I'd like to go back to how I started this talk, a simple story. In my case, a knee injury which did not respond to conventional medicine but did to CAM. These anecdotal stories, such as the one I mentioned, are the basis of research. They intrigue somebody enough to try to use it in a clinical case study, and if the treatment works, to repeat the case study again, and then try it in what's called a case series for several patients. And it's only much later then is the randomized controlled trial done. As you've seen here, there are nearly 6 million people using CAM per year. So for CAM, there are literally tens of thousands of anecdotal stories and case studies. The challenge is to bring this all together and to use it as evidence of not evidence-based practice, but what practice-based evidence. So what is actually happening in practice? So the two ideas worth spreading. Idea one is crowd research. We need to find out a lot more on what people are using CAM for and the outcomes. And what I'm suggesting here is a simple database where people enter anonymously what CAM treatments they've used, which ones they've found useful, which ones they would like to have more available on the NHS. I don't think it would be too complicated to set this up. If Nature Watch can do it for robins, we can do it for those people attending CAM practitioners. The second idea is a database of conditions treated and outcomes, but this from the perspective of the CAM practitioners themselves. We have this wealth of information in the form of these case studies, which are in practitioners' notes. They're not getting out there, not being brought together in a form that really would carry weight about what's happening in practice. Evidence-based practice. So this, I believe, will help move things forward. But the other thing, I think, is that the NHS is in crisis. That although the NHS is considered almost a sacred cow, there are many people behave as though they are what I might call invincible. That no matter what condition or disease they have, modern medicine will somehow be able to fix them. No matter how crazy their diet, their lifestyle, how little they exercise, how much they abuse their bodies, that the NHS will be able to make them better. And we're all living longer too. Patients who go into hospital these days, their operation may be a success, but then they acquire a hospital-acquired infection, which means that their recovery is very much more complicated. There's no doubt that modern medicine today has an extraordinary record in treating many conditions with drugs and surgery. But as drugs lose their effectiveness, hospital-acquired infections complicate the recovery of many, many operations. I suggest it's time to reevaluate the role of CAM. As the NHS crisis worsens, which I think it will, more and more people, I suspect, will turn to complementary medicine, particularly those with long-term chronic diseases for which orthodox medicine is able to offer very little. If CAM is to have a greater role within the NHS, which I believe it has the potential to do, we need to find out first about what is happening in practice, how many people are attending CAM practitioners, what the kinds of outcomes we're getting, before we can then move that into evidence-based medicine, where the policymakers, the people with the purse strings, will then put more funds towards complementary medicine. Thank you.